welcome everybody to our group NeoFOCUS' Friday weekly presentation, where we have the privilege of having Professor Sehgal. I would let Jay introduce Professor Sehgal now. So Jay, please, the floor is yours.
Thank you, Ahmed. It's my greatest pleasure to invite Professor Arvind Sehgal to this meeting. Professor Sehgal is a neonatologist at the Monash Children's Hospital and is a professor of pediatrics at the Monash University, Melbourne. He has been the head of cardiovascular research at Monash's Children's Hospital for the past 13-14 years. And he completed his PhD in 2016 whilst working as a full-time intensivist, and is currently enrolled into the doctorate degree in perinatal hemodynamics. In 2019, Professor Sehgal's research was awarded ANZNN's Emerge Respiratory Research Award, and he was awarded the Professional Excellence in Research Award by the university in the year 2022. He has been a member of the award selection committee of the American Academy of Pediatrics. He has conducted and chaired invited hemodynamic sessions in the PAS annual meeting held in the US. And his current research focuses on cardiovascular adaptations in infants with severe bronchopulmonary dysplasia. And his other area of interest is to do with the hemodynamic consequences of fetal growth restriction. He has more than 150 publications in international journals. And we are really very privileged to have him today. And he's also doing a second session in the next week, Friday as well. Professor Sehgal, the floor is all yours. Thank you.
Thank you very much, Jay, and hello all. Good morning. I think that's the time in UK. So look, I was at Imperial College, I think middle of last year, and developed a good association with Jay. So thank you for the invitation. So as Jay mentioned that this is like a two-part talk. Today I'm just focusing on the cardiac aspects of fetal growth restriction, and next week I'll be talking about the vascular elements as well. So to get the ball rolling, a lot of questions which arise in people's mind that how is it that some of us are more prone to diseases like stroke, diabetes, or high blood pressure? And list of convention answers, of course, we know it's in our genes, kind of diet we eat, do we have a sedentary lifestyle? But another powerful source of influences which have recently been focused on include the kind of nutrition we receive as a fetus, our mother's health, nutritional health, stress levels, psychological health, or state of mind, as we say, while she was pregnant. So pregnancy seems to be a very important period of our lives, and changes which happen in the metabolism, in wiring, in structure, different organs, including the heart, have the potential to permanently change the way we work, we live, and our health going forward. So it's important to appreciate that pregnancy seems to be becoming a new scientific frontier, and how we can optimize maternal health, physical health, psychological health. It's all aimed at how we can prolong pregnancy, increase the birth weight, all aimed at reducing the likelihood of adult onset cardiovascular disease. So we all know this. This is Professor Barker and his work in terms of low birth weight epidemiology and linking with heart disease in middle ages is very well known. As I said, the heart disease originally was considered a disease of affluence, sedentary lifestyles, rich food. And this particular hypothesis has been studied in different countries. And even after accounting for adult lifestyle, socioeconomic status, educational status, healthcare structures, the relationship between low birth weight and cardiovascular disease in adulthood remains very robust. And similar studies have been conducted more than 24 times since then. And this is, I can say, one of the most solidly replicated findings in the field of public health, as we know. Now, if you look at the literature on fetal growth restriction has really exploded, about 1,000 publications every year. If in PubMed you write IUGR, you come to, this is, I made this graphic today, 25,000 odd publications on this topic, and about 1,000 publications a year, and linked with the range of diseases. But the focus today is, of course, cardiovascular disease. So whatever is on the slide, which is in green, I'll be talking about today. I'm not talking about animal data on heart and vessels, and I'm skipping the vascular components for next week, and also not looking at therapeutics for today. Maybe we can talk about it next week, certainly. Now, there are different definitions of fetal growth restriction floating around, and the literature, as you know, suffers from a major drawback where small for gestation age and fetal growth restriction are the words used interchangeably. But this definition of birth weight less than 10 centile for gestation and sex, especially with abnormal Dopplers, that's the definition which is commonly used in the region. And I've used that definition for today's presentation and all my studies in which I'll be talking about today. So I'm going to summarize what's the current evidence on the cardiovascular effects of fetal growth restriction, starting from fetal life to early postnatal life, and also looking at whether what we see in the fetal neonatal age group, that remodeling of the heart, the abnormality in the functioning of the heart that persists into childhood, into adolescence, into adulthood, leading to increased cardiovascular disease mortality. Now, this is the definition by the Committee on Practice Bulletins Gynecology, American College of Obs and Gynae from 2001. And again, they talk about birth weight, and they talk about, linking it with the gestational age and birth weight being less than 10th percentile. Important to understand that we are talking about fetal growth restriction today as a part of placental insufficiency. I'm not talking about fetal growth restriction as a part of intrauterine infections or chromosomal abnormalities. But even within the placental insufficiency, the gestation at which this will develop has a major significance on how the pregnancy will proceed and what the outcomes would be. And broadly, you could say early, late onset, and early FGR is something which starts quite early, less than 32 weeks gestation. There is increased resistance of blood flow across the placenta, and how severe that dysfunction happens is directly impacting fetus cardiovascular status and how the Doppler abnormalities go along. And something which starts a bit later, I would say like 32 weeks and beyond, differs by clinical manifestations with a milder severity of placental dysfunction, and the umbilical artery flows are mainly normal. So within placental insufficiency as a causation, you could split them into two early and late onset FGRs. Now, why placental insufficiency is the issue? Because it affects the fetal heart in two ways. One is the reduction in oxygen supply and nutrients, and that affects the growth of the cardiac cells, the cardiomyocytes. So the number of cells is less, but they are big in size. And that combination doesn't actually bode well for a better function. And second is the fiber architecture is also altered. The second important issue which placental insufficiency brings forth is the villous hypoplasia thrombosis. Again, that's at the level of placenta where there is increased resistance, poor nutrition is being passed on, and that leads to increased afterload on the developing heart. So consequences of this are that the myocardium develops some changes in the microstructure, in the macro architecture, as well as in the function. So a fetal heart which is affected by placental insufficiency initially becomes spherical in shape, is trying to adapt to this less oxygen, less nutrition supply, and increased afterload, adapts by becoming spherical to maintain stroke volume. Now, this might happen in one ventricle, it might happen in both ventricles together. Again, it depends on how severe the affliction is. In more severe cases and in more prolonged cases, this sphericity of the heart may not be enough, to compensate for what is happening. So that contractility becomes compromised. So this progression from three phenotypes like elongated, globular, hypertrophic suggests that this is something which has been long-standing, and the severity is progressing as the pregnancy progresses. Now, a range of echo parameters I'll talk about, which are studied, but amongst them, this sphericity index is something which is quite reproducible. It's not affected by changes in fetal heart rate. It's not affected by fetal movement. So that's something which a lot of obstetricians closely follow in terms of how the heart shape is changing from a normal shaped heart to becoming globular, becoming hypertrophic. Now, scope of the problem, how common it is. Literature in term infants says it's 5 to 10% of term pregnancies are affected. And although a lot of organs are affected, heart seems to be a key organ which undergoes a maladaptive response to reduction in nutrition and oxygen supply. In premature infants, this is data from our unit published a few years back, that amongst infants 24 to 32 weeks gestation, this is what the criteria for data collection is for the Australian New Zealand neonatal network. The incidence at our institution was about 20, 25, 27%. And in the literature, you can see across Australian New Zealand neonatal network, data which is few years old, and data from the US, again, it was accounting to about 18 to 30%. So it is a significantly common diagnosis we face in the neonatal intensive care unit. And these infants survive and go home, and they go into the community and they contribute to chronic cardiovascular disease, mortality, and morbidity. So essentially, in terms of numbers, it's a big public health problem which is developing. Jay mentioned that many of the people in the audience are echo positive, I say. So they just, for their benefit, I just thought I'd just go through quickly about what are the echo markers we look at in the fetal neonatal period, so that when I present the data, you can make sense. So the top two parameters on the left, these are about the systolic function, fractional shortening. This looks at LV cardiac contractility. If you compare all the echo parameters one by one, this is the least sensitive, least useful, but most commonly used parameter. Then we look at the stroke volume from the apical 5-chamber view. This tells you how much blood is being pumped out every time the heart beats. Then we talk about the diastolic function parameters. These are measured across the mitral valve. You can see the mitral Doppler trace here. As pregnancy progresses, the E wave becomes increasing in size and the A wave becomes smaller. So this particular Doppler picture you see on your screen at the bottom, that's a picture of a term baby who's now 3 months old. If I would do an echo in a baby who is a fetus at 24 weeks, then the E wave would be 50% of the A wave. So essentially the EA ratio would be 0.5. And as the pregnancy progresses, the E wave becomes bigger. So at term, this E wave is still smaller than A, about 0.8. But in IUGR fetuses, this E, which was supposed to be small compared to A until term pregnancy, becomes big in mid-pregnancy. So that's a sign that there is diastolic function creeping in. Then we look at the motion of the mitral valve. Again, that tells you how much the heart is contracting. Then there are certain relatively newer parameters from tissue Doppler, which tell you tissue velocity, how fast the cardiac tissue is contracting, and then some information about speckle tracking, which not only tells you the mobility of the left ventricle, but also can split the left ventricle into 6 different segments. So you have a sense that which particular part of the cardiac wall is more affected and which is less affected. So that information gives you is brought together by speckle tracking echocardiography, also known as deformation imaging. If I combine all this information, I can see here from the left side, the fetus heart is gradually adapting. You can make assessments in longitudinal plane, radial plane, ejection fraction, cardiac output I talked about. I talked about the myocardial performance index. I talked about the E ratios, displacement, and tissue Doppler velocity. And at the end, this is the strain imaging. So from left, you can see the heart is gradually adapting. Then there is cardiac dysfunction assessed by the ultrasound. And then at the end, there is clinical cardiac failure. Sometimes babies are really at terminal when they come for ultrasound, and the delivery has to be planned quite quickly. So how does the heart adapt? So this is the initial insult where there's placental insufficiency, and that leads to hypoxia. Nutrition supply is hampered. That leads to volume overload and pressure overload because of increased resistance. So what you see on the left side is a normal looking heart, but on the right side, what you see is because of increased pressure, initial part, the heart becomes globular, and that's a sign of mild placental insufficiency. If that baby is not delivered at that time, or the pregnancy progresses and this insult continues to be there, then the heart becomes hypertrophied. So severe placental insufficiency would present as a globular hypertrophied heart, and that is linked with worse cardiovascular outcomes. In addition, when you look at the early FGR, I mentioned less than 32 weeks gestation, there are abnormalities noticed in the uterine artery Dopplers and umbilical artery Dopplers, and then redistribution in the middle cerebral artery. And then with the late FGR, where the start of problems is at 32 weeks and beyond, then you have placental insufficiency changes in the uterine artery and the cerebral placental ratio and aortic isthmus. Summarizing what I said just now, the changes which you see in the prenatal period, that's a normal heart, that's a globular hypertrophied heart. Similar changes appear when you do an ultrasound between 3 to 6 years or 8 to 9 years, and exactly same changes you can see comparing the normal control and IUGR adolescents. So the problem which started during the fetal life because of placental insufficiency doesn't go away, even though that particular situation has been sorted out. So baby is now delivered, is outside, and might be having good nutrition and lifestyle, but the changes which were established during fetal life tend to persist for a long time to come. So in fetal echocardiography, as I mentioned, the shape might change, the tissue Doppler velocity is reduced, so there is subclinical systolic dysfunction. There is diastolic dysfunction, as I mentioned, in terms of abnormal transmitral EA ratios, and also the changes in isovolemic relaxation time and the myocardial performance index. So these changes tell you very early that this fetus, at least from the cardiovascular point of view, is not doing well. Now, speckle tracking, as I mentioned, it essentially tells you it's called deformation imaging. That from the original shape of the wall, how much can be deformed. So less deformation means a stiff myocardium. That is what it means. Now, this is fetal echo, and I will show you our own data on speckle tracking in postnatal age, and you will see that this particular modality is very sensitive. And if you do a clinic for IUGR pregnancies, then within the FGR cohort, this technique will pick up the high risk group within the IUGR group. So in case you wanted to have a close follow-up of 10 patients out of the 50 patients you see in the IUGR clinic, this technique will tell you which one to monitor more closely. So this is what it looks like. These are term infants at 40 weeks. This is a normal pattern you can see, but here in the IUGR fetuses, you can see this is called post-systolic shortening. And that signifies that the basal segments of the heart, not the apical, the basal segments of the heart are more affected as compared to the mid segment and the apical segment. So basal segments of the heart are more prone to hypoxia ischemia compared to the apical segment. So hold this thought for some time. This is fetal data, and I will show you exactly similar data from the postnatal age groups here. So going to The shapes of the heart I talked about, changing from globular shape to myocardial hypertrophy as the pregnancy progresses. And in the textbooks, these hearts are described as globular hypertrophied cardiomyopathy-like hearts. Let's come to the neonatal period now. So some data from premature infants. So this is a study looking at a wide range of premature infants, 23 to 32 weeks gestation. And they did echocardiograms in the first few days, then at the end of the first week, then at the end of the second week or so. So 25% of these infants had a significant PD. So that itself can affect the LV volume and dimension. So what I present for this particular study has to be kept in mind that PDA would have an important significance. They also did cord blood BNP levels, which were higher in IUGN infants, and they were correlating with how thick the septum was and the dimensions of the LV in terms of diastole. So what you see on the left side is the white bars are the AGA preterm infants, and then the black bars are the FGR infants. You can see here there is thickening of the septum and the heart is dilated. But when you look at the cardiac function, then you can see from day 1 all the way to day 14, as the cord is clamped, the afterload increases and the left ventricle is asked to contract against a higher resistance now. So the LVO increased during the study in AGA babies, but the FGR infants, the LVO did not show further increase during the study period. So essentially, this population, there is a failure to like physiological increase in LV output when faced with increased resistance from the left side. That's not happening. So it's possible that preterm FGR infants may be exposed to a higher risk of circulatory failure because they're not able to adapt to the postnatal period as smoothly as the preterm AG infants are able to do that. And again, as I mentioned, the fractional shortening parameter is not going to give you this information. This is some of our own work, which we did in 2013 or so, 2017, sorry. So this is a cohort of preterm infants, and we were doing echoes in these infants at the end of, middle end of second week. And the idea was that by then, the PDAs would have closed spontaneously. So this is data which is not so much influenced by the presence of PDA. So these are the morphological parameters on this table. In this table, the first column is the infants with growth restriction. Second column is the AG infants. Then I've got unadjusted difference data, and then gestation age adjusted data. And what you can see is, again, what we saw in the previous study and what we saw in the fetal ultrasounds, that there is thickening of the interventricular septum as well as LV free wall. When we look at the cardiac function parameters, again, diastolic function parameters on top and the systolic function parameters at the bottom. And as you can see here, there is impairment of diastolic function as well as the systolic function seems to be affected. So again, as I said, textbooks describe these hearts as thickened, dilated cardiomyopathy-like hearts. Coming to the term infants, and these term infants, as you know, they are otherwise asymptomatic. They're born by normal delivery or by C-section. They stay with the mother in the postnatal ward. By day 2, day 3, day 5, they go home with the mother, never really to be seen in any kind of follow-up until they present to a GP who does a blood pressure measurement. They're found to be hypertensive, or they fail to thrive later on, and they turn up as early onset diabetes. So those are typical presentations of these infants. So this study looked at the heart from conventional and tissue Doppler assessments in the first few days, and then 3 months, 6 months down the line. And again, as I said, fractional shortening, while it's a very commonly used echo parameter, is not sensitive enough to tell us the difference between the two groups. But even by day 3, you can see the hearts are dilated, the cardiac output is low. The diastolic function parameters I mentioned earlier on, they're already affected. And many of these differences persist when they were re-evaluated at 6 months of age. And the blood pressure in these cohorts, which was much higher compared to the AG infants. This is again some study from 2014, term infants with growth restriction, otherwise asymptomatic. They looked at conventional and tissue Doppler echoes in the first week on day 2 and day 5. So the white box whisker plots are AGA, then the FGR on the right. And again, you can see FGR infants had septal hypertrophy. And from day to day 5, the very similar to the preterm infants, the AGA infants increase their stroke volume and decrease their MPI, which means better output, better relaxation. But the same thing is not happening in the FGR cohort. So their adaptation to the postnatal hemodynamics is poor as compared to the AG infants. And again, the blood pressures in these cohorts were higher compared to the AG infants. This is some of our own work from 2013. We looked at 20 FGR infants. We did one cross-sectional echo between day 2 and 5 of postnatal life. Again, the blood pressure was higher in this group. And you could see here the LV output, systolic function, diastolic function, both are compromised. I was talking earlier about spectral tracking cardiography, also known as deformation imaging. And this is looking at these infants analyzed with this modality. Now you can see here there's a number called global strain. Now it's minus 10%. Normal is about minus 25%. So that's a difference you can see here. But what is more important here is not only the global strain is less, which means this myocardium in FGR cohorts is very stiff, so it's not able to change or deform easily. But within that, the basal segments are affected more often or to a much significantly higher extent as compared to the apical segment. And you recall a few slides back, I had shown you some information on fetal echocardiograms that even in them, the basal segments were affected significantly compared to the apical segment. So you have this continuation of echo findings from the fetal life to postnatal life, in spite of the fact that placental insufficiency, lack of oxygen, nutrition is not there anymore. But even 2 weeks down the line, you're continuing to see these changes which started in the fetal age group. So this is a summary of the neonatal echocardiography. Again, conventional parameters tell you a story, and also the advanced parameters tell you a story. And many of these studies looked at other troponin levels and BNP levels in cord blood. Again, they are higher, suggesting that there is some level of myocardial injury going on. Now the question is, why is this happening? So the pathophysiology is actually multifactorial. Very important to understand that placental resistance is key, and that affects the arterial structure and tone, which I'm going to talk about next Friday. But this reduction in oxygen and nutrient supply can also directly affect the heart. So the heart architecture undergoes change. There is decreased contractile proteins, increased collagen deposition, and as I said, the cardiomyocytes are less in number, but more in volume or size. So again, the combination of that is heart is not particularly contracting very well. And between the systolic and diastolic function parameters, it's the diastolic function which gets compromised first, because that really depends strongly on how the heart is shaped and the torsion of the heart, as well as how the architecture of the heart is evolving. If I move forward from the neonatal world to see what happens to this population as children and adolescents. Okay, so children, I'm talking about 3 to 6 years of age who had FGR. When they are assessed at 3 to 6 years of age, they continue to have globular hearts. The longitudinal motion is less. They're impaired relaxation in 3 to 6 years, as well as from 8 to 10 years of age. Now, whether it's a milder form of growth restriction, they tend to compensate the compromise in longitudinal motion by increasing the radial function, while severe FGR, they're just not able to have adequate compensation even by increasing the radial motion. So they are more affected as compared to the milder growth restricted populations to start with. But nonetheless, this cardiac remodeling persists even in pre-adolescence, which is about 8 to 12 years of age, no matter what level of growth restriction they started with. If I take this story a little bit further, so this is a cohort study of more than 150,000 adolescents in Sweden, and they look at systolic BP significantly higher in young men who had the lowest birth weight. Generation R study, which is a population-based prospective study starting from fetal life into adulthood, this started in 2006, and now it's like the protocol was published in 2016. And this is following this population well into adulthood. But what they've seen already is very important, is that fetal hemodynamic patterns already show a change when the fetal growth is faltering. So they don't have to reach less than 10th centile in fetal estimated weight. Even at from the 50th centile, if they reach 25th centile, you already start seeing fetal hemodynamic patterns. So very important for obstetricians to say, okay, when is the right time to deliver this pregnancy? Do we let the fetal growth go all the way down to less than 10th centile so they can fulfill this box? You can tick the box to say, yes, this is IUGR, or should we deliver them early because fetal hemodynamics is already undergoing a change? So this decrease in fetal growth triggers cardiac remodeling and reduction in cardiac output. So you already have telltale signs that it has started and it's likely to persist much longer, even though the weight has not reduced to 10th centile just yet. Now, this is again looking at few years before Barker's hypothesis was proposed, a link between low birth weight and hypertension as a cross-sectional study. Then the study, 15,000 Swedish men and women, 97% follow-up over a 50-year period. Again, strong correlation between low birth weight and death from ischemic heart disease. We're not talking about death from any other or all diseases. We really focused specifically, it is specific, this linkage with circulatory diseases like ischemic heart disease. This is a study from the US, more than 120,000 American women, again, strong negative trends of recorded birth weight with incidence of non-fatal coronary heart disease and stroke. So across populations, the message is pretty much the same, that the smaller you are at the time of birth, which reflects what happened during fetal life in terms of inadequate nutrition or maternal health was compromised, it is linked with higher death rates from ischemic heart disease. Very important cardiovascular risk in young-fin study enrolling about 3,500 children and adolescents aged 13 to 18 years. And so there are two timelines for this study. At average of 31 years, those children who were born small, like 10 centile or less, they already had a marked increase in triglycerides, cholesterol, blood pressure, and intima media thickness in the aorta compared to the controls. More recent follow-up is from 34 to 49 years. You can already see the difference in heart size and lower cardiac output is persisting. This is study, Enigma study. Some of you might be familiar. This is a study from UK, long-term follow-up study, close to 1,000 young individuals. Again, you can see there is an increase in systolic BP and central pulse pressure at the age of 21 years in the cohorts which were born small. And similar findings are seen in young adults from the US. So whichever way you look at it, the problems which started in the fetal life tend to persist for a substantial period of time going forward. Just wanted to touch upon this particular issue. And a lot of parents, you think, baby is born small. I need to feed this baby in such a way that the baby becomes like, almost equal to the weight of a term AGA baby. The idea, misconception is a bigger, heavier baby is a more healthier baby. So if you plot these weights on centile charts going from birth all the way to 3 years or 6 years or so, you will see very commonly that they're not following their centile chart. They're actually jumping centiles and going higher than what they started from. Is that a good thing? Not really. It's not a good thing. In the cohort of Finnish men, the cardiovascular mortality was also increased as a result of rapid weight gain in the first years of life. So within the IGR cohort, if you look at who is likely to die from cardiovascular disease more often, then the cohort which had a rapid weight gain in the first few years of life is the one to focus on. Then you look at increased mortality rate was also confirmed in obese men who between 7 and 15 years of age, their BMI was above average. So both men and women who have a lower birth weight and subsequent obesity, and that's what I'm trying to say, that crossing of centile charts is not a good idea. They have this double hit, the highest cardiovascular disease rate. So that confirms the critical correlation between not only fetal life, but also early life environment and how it impacts cardiovascular disease during adulthood. Now, this figure is summarizing what I've mentioned until now, from fetal life to pediatric age group, young adults, mature, old, changes in the heart structure, increase in thickness of the arteries. Those things persist and they can be analyzed later on. Now, of course, on top of that, if you add the lifestyle issues like tobacco, high-fat diet, sedentary lifestyle, that tends to affect further increase the morbidity and mortality. Of course, there are redeeming features of healthy lifestyle, and these are the things which we tell parents when we have growth restricted cohorts delivered, that how to modulate. Certainly, we don't want to alarm them, but certainly how to modulate things from going forward. What is important to appreciate is opportunities for correction. As time goes by, those opportunities of correction become slim. So better act early compared to later. People might think, why all this is happening? Just want to touch on that. There are two main pathways. One is metabolic programming, one is cardiovascular remodeling. And many a times, these things interact closely with each other. And this figure summarizes what I wanted to say, that metabolic programming is something which starts during fetal life, risk of metabolic syndromes, increased risk of abnormal glucose tolerant test, or non-insulin dependent diabetes, and also the cardiovascular programming. So they closely interact with each other. And in a combination of this is, of course, increased cardiovascular disease or cardiovascular disease mortality. Now, looking at the bigger picture in terms of what are the main changes which happen during fetal life. So, of course, we talk about placental insufficiency, which is characterized by reduced nutrition, fetal hypoxia, volume overload, pressure overload. So that changes the cardiac architecture. And on top of that, you can see very important epigenetic changes like DNA methylation, histone modification. So together, they affect the heart and other organs as well. And when we look at the heart on the right side, there are things you can make assessments using ultrasound, like cardiac function parameters, as I mentioned in detail, but also on an organ level, the fiber orientation is changed. There is increased intima media thickness of the vessel wall. When you dip down into tissue level, then you can see the number of cardiomyocytes, as I mentioned, is less, but they are bigger in size. But bigger in size, small in number, that's not a setting where cardiac function would be normal. Then if you dip down further into subcellular level, you can see the sarcomeric length is also less, and mitochondria is rearranged in a very abnormal way. So this summarizes generally the triggers on the left side and how the heart is affected on the right side, beyond what you can make assessments by echocardiography. So the take-home message from my presentation today is this, that subclinical cardiovascular disease, as I mentioned, many of these term studies I mentioned, these are healthy term infants who are growth restricted, but sitting in the postnatal ward, ready to go home with the mother. So if you do an echocardiogram, you will find subclinical cardiovascular disease. So they are not symptomatic, they're not hypotensive, they're not hypertensive, they're not acidotic. And that is why it's termed as subclinical, flies under the radar, begins to evolve very early in life, and long before the clinical symptoms will appear decades later. And there is strong data, epidemiological data, data from biochemical studies like troponin, BNP, certainly very strong echocardiographic data that supports that this might be starting before birth. And epidemiological studies have shown that low birth weight is strongly associated with higher risk of coronary artery disease, stroke, hypertension, NIDDM. And this association goes on from neonatal life to pediatric age group to pre-adolescents to young adults, all the way up to 55 to 70 years of age. And these associations stay true beyond what you can say lifestyle changes, disparities in life expectancy, or which healthcare care system you are living in. These associations stay true even once adjusting for all this. So this is my last slide, and it's important to appreciate, as I mentioned earlier, that about a quarter of the population in the world is born either too small or too premature, and that's a major public health issue. We don't particularly grasp the importance of these issues until they present clinically later on. So this group needs to be addressed on a priority. Now, before I finish, I just wanted to mention about a cardiovascular symposium we are organizing. We organize it every 2 years at Monash Children's Hospital, which talks about a lot of these issues and also any cardiovascular issue of clinical importance in fetal life, neonatal life, and pediatric age group. So most welcome if you wanted to come over. Just go to Eventbrite and type Monash Cardiovascular Symposium. Registrations are open from today. Thank you very much for your time and happy to take questions.
Thank you, Arvind. It was just absolutely fascinating, the overview of this element of growth restriction, and also it's a great representation of the huge amount of work that you have been doing over the years, and we are really it's really great to see all this. So I think there are a few hands are up. So just unmute and ask questions. So yes.
Thank you very much, Prof. Sehgal. I have no doubt now you convinced me completely that the changes from the fetal UGR going to the life are persistent. So the next question logically is, can we affect that? Can we modify that? Can we, at any level, intrautero, in the neonatal period or late in life, to modify the changes, or can we modify the changes in utero? So I know it's very unusual questions, but our logic asks that. Can we do something about that? Thanks.
Thank you. I think it's a very important question. In many of my talks, I'm asked this question. I purposefully left the therapeutics to next Friday because a lot of those therapeutics work on the vascular level. And the component of hypoxia, ischemia, or lack of nutrition, which is directly affecting the heart, that's one component. But many a times the heart is reacting to what is happening in the systemic circulation. So if the placental vessels are affected and the placental vascular resistance is high, the heart is possibly adapting to what is happening in the placenta. So there are drugs which are our group. I mean, I work with a group of scientists. They are either the studies are ongoing or they are planning studies. And I can tell you, oxidative damage is one important key mechanism. So investigators are using melatonin as an antioxidant in randomized control trial in IUGR pregnancy. So that started as soon as it's diagnosed and they continues until the baby is delivered. And for the moment, they are looking at long-term neurodevelopmental outcomes. But the heart and the vessels and the lungs are important to focus upon as yet, because the pathophysiology mechanism that if it's antioxidant injury is relevant there as well. The second intervention we have submitted a grant for, which we will find in due course, is antenatal use of ACE inhibitors. So ACE inhibitors, as you know, they work on multiple channels. They also look at improving endothelial function. They also affect the architecture of the vessel wall. So if the arteries are thick and stiff and the endothelium dysfunction is a major factor, then ACE inhibition in experimental models is something which is physiologically very relevant. So those two things, which the melatonin is a human trial, and the other aspect is more experimental, looking at the um, results from the sheep model. But I'll present next week some data from the Spanish group, which looked at, it divided the pregnancies into three parts, three groups. And what was common in these pregnancies was they previously had an IUGR delivery. That was common. That is how they were recruited for this trial. So they have 1,200 pregnancies in the trial. One group was standard perinatal care. One group was special nutrition, like Mediterranean diet. And the third group was standard diet, but a strict regimen of uh, mindfulness, like stress reduction therapy. So I'll talk in more detail about that when I come next week. And they were comparing one, birth weight and incidence of preeclampsia in that pregnancy, and also whether this was able to prolong the pregnancy. So on all three parameters, uh, Mediterranean diet versus standard, and standard diet but stress reduction therapy versus standard perinatal care, both were significantly better in terms of birth weight, less preeclampsia in this pregnancy, and prolonged pregnancy. So beyond like therapeutic interventions like melatonin or ACE inhibition, there are a lot of other things we could do which really importantly change the trajectory of this pregnancy in terms of fetal health.
Arvind, just to add on to this, and I just wanted to get your thoughts on this. Do you have any like? Is there any studies ongoing or any thoughts ongoing about trying to solve it at the source, which means the mothers? And the reason I'm asking, because our group here at Imperial, the fetal medicine group, so they published a lot of work on looking into the maternal cardiac output and maternal hemodynamic functions and arterial stiffness, etc. And what they have found that in an AGA, appropriately grown babies, the cardiac output increases in the second trimester, which is all we normally know. And what they have found that babies whose mothers don't increase this cardiac output in the second trimester, they go on to develop small babies like SGA type babies. Whereas if there's another group which they found that their maternal cardiac output actually decreases. And in addition, there is also increase in arterial stiffness resulting in increased afterload as well. And these are the group of mothers who then develop babies with FGR. So my question is whether we can do anything at the source to try and prevent this happening, to modify the disease at the source.
Very interesting intervention, Jay. I'd be interested in seeing what is done and what can be done. My feeling is that the maternal hemodynamics are reacting to what is happening in the fetal placental unit. And the reason I say is that there was a study published in American Heart Association journals, JAMA network, I think about 3-4 years back. And what that study was looking at, they were looking at mothers who have given birth to 4 types of babies. One is term AGA babies, term IUGR babies, preterm AGA babies, and preterm IUGR babies. So those babies have been born, and they are looking at the mothers 4 years after giving birth to that baby. And what they were looking for is stroke and cardiovascular disease mortality. And the preterm IUGR babies' mothers were at the highest risk of dying in the next 4 years. So the hypothesis was that this fetoplacental unit, which is gone crook for whatever reason, is affecting not only the baby, but in some way, shape, or form, it's affecting the mother as well. So the question is the fetoplacental unit releasing some biomarkers which are changing the maternal hemodynamics, or as you rightly say, that maternal intima media thickness or cardiac output is getting compromised? Is what is coming first? Is maternal illness coming first that is affecting the fetal placental unit, or it has started in the fetal placental unit affecting the baby and the mother? So I think we need more data, interventional data to sort out what's actually happening.
So, you talked about the biomarkers. I think that's another things that the TRUFFLE-2 study is actually looking into several biomarkers of cardiac function in the mother's blood. And I think you will get some answers to the mainly looking at the late growth restriction babies, not the early growth restrictions. And they are quite different types. You all know about the Delphi criteria for the fetal growth restriction that was published, I think 2016 or something, and in Europe, I think it's called Ultrasound of Obstetrics and Gynecology (UOG), and the definition that we normally use, and actually most of the studies have been done on early growth restriction babies. But as you rightly said, the late growth restriction, especially the late preterm babies, and also the term babies who are growth restricted, there is very little research done on them. And they are actually quite a larger group compared to the early growth restriction babies. Sorry, I think there are quite a lot of hands up. I'll leave my questions. I have a list of questions, but we can ask you later on. Ahmed, you're first, and then Sujit, and then Anne-Marie. Ahmed.
Professor Sehgal, thank you very much for a really eye-opening talk. Amazing, really, thank you. So the cohort we are talking about, many of them would be completely asymptomatic, would maybe never come under the radar clinically. So while you're, as a researcher, you're making a great contribution, as a clinician, how much of this is part of your existing practice? So these low birth weights, asymptomatic, maybe. Is there, what do you practice? Do you identify them? Is there a plan for doing an echo? Do you identify early CVD and do you put them on follow-up? So how much is in practice right now at your end? Thank you.
Thank you. Important question, and again, a question which is asked every time I give this talk. So the link between the fetal and neonatal period is quite strong. What we see in the fetal life, and I work with the fetal ultrasound people, and once they come to the nursery, we closely follow them. The term IUGR babies who never come to the nursery, they fall through the cracks. We have no way of following them. But going forward, once they are discharged from the nursery, then the follow-up has to be, I think, not only cardiac, it has to be developmental follow-up, it has to be nutritional follow-up as well. Because as I said, a lot of these babies, they cross centile charts to become as a catch-up theory. So we don't have that in place just yet because of logistic reasons. But between the two, the term IUGR babies are just not followed up. We are trying to establish some links with the PEDS cardiology department to say, okay, babies within FGR cohort now. So if 25% of preterm babies in my unit are growth restricted, which is in 3 years 206, we don't have capacity to follow 206 babies. Within that cohort, if I can identify the highest risk category, which is in the neonatal period, I will do spectral tracking, as I mentioned. So within that high risk group, if I can find, okay, out of these 200, these 20 or 50 are the ones I want to follow. That's a manageable load. And that is what we are working on.
Thank you. Thank you very much.
Thank you. Sujit?
Thank you so much, Prof. Sehgal. I'm Sujit. I'm one of the neonatologists based in London. I'm fascinated to hear your talk, and I was curious to find out why basal segments were more affected than the apical segments. That's one question. And the second question I had is, you mentioned about the LV systolic function, and I was curious the impact on the RV, especially that given that the architectural fiber and things are very different in the RV. And I was curious to find out what's happening with the RV in this cohort. Thank you.
Thank you. Very, very important question. So the reason basal segments are more affected, if you look at the fiber arrangement in the basal region, is very different. It's more circumferential versus what is, in mid segment or apical. So ultimately the whole heart will be affected, but it's which part of the heart is more predisposed, and the way the fibers are arranged, more closely stacked as a group, they get more affected and easily affected very early on. Most of the data you rightly picked up is focused on the left ventricle. Because the thought has been that the LV is the one which is going to be interacting with the placenta. So, and once you are born and the cord is clamped and cut, then of course the systemic vascular resistance is likely to go up. And again, it is going to be impacting the LV. So my impression is a lot of information related to the heart is focused on LV for that reason. Now, if you look at between the two ventricles, a lot of crosstalk is happening. They share the septum and a lot of fibers go across. A lot of crosstalk is happening. So it would not be surprising if the RV is affected equally or more. And metabolically speaking, when the baby is born, you do an ECG, it's RV dominant ECG, which tells you that during fetal life, the RV is the more metabolically active ventricle. It is contracting blood. Blood's not going into the lungs, but it's going across the PDA to the left side of circulation. So the RV essentially is a chamber which is contracting against a non-functional fetal lung, which has high vascular resistance. So you expect that RV to be equally affected. There is some work which I will present next Friday, which is more vascular work, looking at what happens to the pulmonary artery. And with that, I've shown some data on RV. So I can tell you it is affected. And if I compare the two between RV and LV, RV is more affected compared to LV. But again, in the literature, human neonatal literature, or there's no human fetal literature looking at the RV, but human neonatal literature, one or two studies, and one of the studies is ours in Journal of Physiology. So if you join in next week, I will be happy to share with you.
Thank you. Thank you so much.
Thank you, Arvind. Anne-Marie? Anne-Marie, are you there? Your hand is up. Yeah.
Yes, I'm able to speak now. Thank you so much for what's an absolutely fantastic presentation. Really wonderful. I recognise a lot of it in what we instantly see in our preterm babies, and as you've suggested, it affects probably 25 to 30% of them. I was really interested in your slide that talked about the ability to recover and remodel during early childhood. And I just wondered, given the high instance in preterm populations of these sort of abnormal myocardial developments in utero, if you advocate exercise programs during childhood. It's something we've been considering in our own preterm clinics, and it's maybe something you're going to talk about next week, but I was just curious. Thank you.
So yeah, look, as one of the range of recommendations, of course, sedentary lifestyle is never good for anybody. So a range of exercises and healthy diet. The group in Sydney has looked at before pregnancy supplementation with fish oil to the mother, and continuing with fish oil drops until 6 months of age. And they have looked at reduction in blood pressure and also the thickness of the intima media at the aortic level. So all these interventions are relevant. It's difficult to say to parents who are taking a newborn baby home that make sure your baby exercises well. I mean, that's a recommendation intervention which comes into play, maybe 1 or 2 years down the line. And that is where the role of follow-up of these cohorts is essential. I would not see these babies at 2 years or 6 years of age, but at the very least, if we can alert the parents to say, look, there is an issue here, it flies under the radar for a long time to come. You plug in with a GP or a pediatrician who will give you proper advice, including dietary advice and exercise advice. And I think that's the key to tackle this. But again, as you say, the interventions have to be age appropriate.
Yeah, I think, Arvind, one of the biggest problem we are working on is there's a complete ignorance of the cardiovascular risk of these babies in the long term. And everybody is talking about neurodevelopment, and there are neurodevelopmental physicians and other things to follow those people who have problems with neurodevelopment, but there is very little there in terms of the service provision, follow up babies in the long term in terms of cardiovascular service provision.
Can
I think
they measure blood pressure? I think the easy thing to do, isn't it?
I think that's one of the things that we are now actually installed in our initiated in our hospital is every babies who are being followed up in the clinic, we're trying to get blood pressure on all of them in every time they come in. Even if they are small, until at least up to 2 years or even longer. And I think that's, as you said, is one of the very simple things that you can do to try and identify disease states very early. I wanted to ask, what there are so many tools and parameters are there, obviously, to evaluate fetal growth restriction heart. What in your mind is one parameter that you will think would be the best way to pick up, even if it is very difficult one? What do you think would be the one parameter that you would want to maybe follow these kind of babies up over a longer period of time?
Well, that's a difficult question. The choice between the best and the easiest. If you want to get a detailed, thorough information, then different modalities of parameters of echocardiography, that's the way to go. Will give you information about systolic, diastolic function, and early onset, more sensitive parameters, less sensitive parameters. But I appreciate logistically that can be a nightmare, funding, staffing, and all. I had some slides which I ran out of time, so I had kept in the background is ECG. There is ECG data in children, 3 groups: controls, preterms, but AGA and preterm IUGR babies in childhood. And ECG will show you, maybe if I have time next time I will show you. It's an eye opener. Even with a simple ECG, you can make out, and maybe you can say, if I've got 100 patients in the clinic and everybody is getting an ECG, I will do echocardiography on 20 of them in whom I see, stark changes on ECG. So that's one aspect. And the third aspect, which I would strongly recommend neurodevelopmental people can do it, is, urine dipstick. If there's a baby who's leaking protein in the urine, having microalbuminuria, they need to be seen by someone who wants to look at the heart as well. There is a strong link. The cardiorenal syndrome. We just finished a study. The data is being tabulated in these 2 cohorts to see, how much protein they leak and is there a difference between the 2 groups. So those are easy to do. If I say ECG and urine dipstick for protein, that will pick up a population, and within them you can say, okay, these are the high risk amongst the high risks, and they are the ones I want to follow up more closely.
So that's one of the questions which I kept in the end, but you have answered. So the renal function associations, I guess maybe in the next talk you'll say a little bit more with your arterial function assessments and things.
I can. Renal data is, so we just 2 weeks back finished that study. So I'm not sure I will have that data ready. There's a 40 babies to be tabulated, but I will draw some conclusions linking with arterial health. Definitely I will.
I wanted to ask you with a kind of cardiac output related question. So you said that, you showed that that slide where it said that cardiac output does not increase physiologically in the growth restricted babies compared to the AGA babies. What do you think is the clinical effect of that? Or is it subclinical?
It is subclinical to start with. The question really is that, how babies compensate hemodynamic compromise. The main way of compensating is increased heart rate. And if cardiac output has to be increased, then the cardiac architecture has to be ready for it. So if essentially what I meant to say is the transition from fetal to neonatal life, if it is smooth, this baby is born, term IUGR, staying with mom, go home, maybe that stays subclinical, no issues. But if this baby comes to the nursery and, for example, develops sepsis, then the ability of that heart to handle that will be interesting to monitor, to say, okay, if you're not transitioning well from the fetal to neonatal life because your myocardial architecture is compromised, and then something else happens, for example, asphyxia happens. So how are you going to fare? Poorly, or you're okay? So as I said, I work with a group of scientists who work on the sheep model, and there is a study which is almost complete now comparing asphyxial insult in fetal lamb, comparing the IUGR model with the AGA model, to say, because we know there is cardiac architecture affected, then if you are exposed to hypoxia, ischemia, then what happens to you? So that is what I meant. You really need to be born in absolutely good shape, so that any extra insult which is thrown upon you, you are able to handle that. So that may not be the case if you are compromised during fetal life.
Okay. Thank you, Arvind. I think we are over our 1 hour scheduled time, and it will be quite late there. I think it's 9 o'clock, past 9 o'clock there in Melbourne. If there is no other questions, can we close this today? And thank you, immensely. This is absolutely fascinating. Our whole group will be enthralled with when they hear this recording. The rest of the team there around. So we are really looking forward to the next week, next Friday lecture on the vascular function, on the vascular side. So thank you, Arvind. Thank you very much.
Okay, thank you. See you next week. Bye-bye.
See you. Bye-bye.
Thank you.
Okay, very much. Bye-bye.